Hey, everybody.
Hi.
All right. We'll give everybody a couple of minutes to join before we get started.
Hi, Tim.
Good morning or afternoon. We got the good-looking group today, it looks like. All right, we'll wait one more minute, okay? All right, can y'all can see me, hear me, see my slides okay? Okay, all right, we'll wait to 12:04 and we'll get started. All right, that's enough. We'll go and get started. So today we are going to talk about toxic shock syndrome. So this noon report is going to be a good bit shorter than what we've done in the past. I've kind of tweaked the presentation a little bit, trying to get us a full session here, but ultimately I was just kind of adding fluff where it wasn't needed. Alternatively, if you guys want it to last a full hour, I can talk really slow and drag it out, but if not, we'll have a shorter session today. All right, so let's see. There we go. So I don't have any conflicts of interest. In terms of our objectives today, once you guys have become familiar with the etiologies of toxic shock syndrome, understand the pathophysiology of toxic shock syndrome and the role that endotoxins play, you should be able to recognize and diagnose this disease process, and then lastly, know how to treat it. Okay, so as is tradition, let's start with a case. So we have a 24-year-old female who comes into the ER with fever, erythematous rash, and nausea and vomiting. She's a little hypotensive and she's tachycardic. She's drowsy, but she's still oriented, and she's able to tell you that for the past week, she has been on this extended camping trip. Okay. like all good hospitalists and hospitalist APPs, we take a thorough review of systems, and we find out that she's been on a menstrual cycle this past week while she's been camping and has had limited access to tampons. All right, so being the astute clinician that you are, you become concerned for toxic shock syndrome. You start fluids, you start broad spectrum antibiotics, and have her tampon removed. Which of the following adjunctive therapies should you also consider? Okay, so here are the options. If you guys will throw in some letters on the chat. So your answers are Clinda, IVIG, Doxy, or plasmapheresis. All right, getting a lot of A's. Well, anybody want to be brave and answer? Okay, there we go. There's an IVIG. Good. All right, so let's dive in. So usually when I'm giving a presentation, I like to go over the anatomy, the physiology, the clinical presentation, the treatment, yada yada, and then kind of review at the end. But I want to take a slightly different approach here with toxic shock syndrome because it's like it's a little bit harder to get a great understanding doing it that way. So I want to start with a very succinct overview, then we'll break it down a little bit, and then we'll come back and review again at the end. So kind of a toxic shock sandwich, if you will. So here's the Cliff Notes versions. Toxic shock syndrome is an underrecognized, okay, that's an important distinction to make, and highly fatal, another important distinction to make, disease process caused by staph or strep, and is primarily a toxin-mediated process, another important distinction. Ultimately, this results in fever, rash, capillary leak, and subsequent hypotension and multi-organ failure. Okay, so let's dive in a little bit deeper and see where we go. So let's talk about the bacterial etiologies of toxic shock syndrome. So the overwhelming majority is going to be caused by staphylococcal and streptococcal species. Okay? Then you can further delineate the staph etiologies by menstrual related toxic shock syndrome and non-menstrual related. So the history behind this disease is that in the mid 80s, there was a new tampon put on the market that was hyperabsorbable, and we started to see a lot of patients get really, really sick, and it seemed to be related to the new hyperabsorbable tampon. So since then, that particular tampon has been removed from the market, and we've seen a slight decrease in menstrual-related toxic shock syndrome, though it still occurs, and a lot of times it's due to prolonged use of a single tampon, as we saw in our case with the patient camping. And then we also have non-menstrual related staph toxic shock syndrome. A lot of the time, this can be post-surgical. Also, it's not uncommon to see postpartum wound infections that result in toxic shock syndrome. Then you have this other, which is virtually any other infection that can be caused by staph. So you name it: skin infections, pneumonias, osteomyelitis, sinusitis, mastitis, burns, septic arthritis, kind of a broad array of different things. When it comes to strep, most of the time when we know where it comes from, it's coming from the skin or the oral pharynx. But a lot of times it's unknown. So that's different than other, whereas with the staph, the other really incorporates a lot of other infections. But with the strep, a lot of times in this condition, even when we isolate a bacteria, we don't know where it originated from. And then you have your super rare etiologies with other groups of strep, Yersinia, Clostridium, but the overwhelming majority of these cases are due to staph or strep. All right, so let's talk about toxins. And I have to pause because I hate this word. It's probably my least favorite word in all of medicine, and it's because virtually 100% of the time, if you're not a healthcare professional and you're using the word toxin, you're using it incorrectly. it kind of bugs me, but it is actually important in this disease process. So let's talk about the toxins that play a role in this process. So first we have up, oh, that's the wrong picture. I meant to throw that one up there. So we have superantigen and the M protein. So as previously mentioned, toxic shock syndrome is a toxin-mediated disease. So what I mean by that is you have the symptoms and the downstream effects of the local infection, but beyond that, most of the presentation is due to what the toxins are doing as opposed to the localized disease process. And there are two main toxins here that play a role, like I said, the superantigen and M proteins. So let's talk about superantigen a little bit and why they're so potent. So this cartoon shows the typical process in which antigens are exposed to T cells. So this blue and green oval here is a normal antigen. And when normal antigens are presented to T cells, it can activate up to 0.001% of T cells, okay? So not a ton. Now contrast that to superantigens who can, which are able to activate up to 20% of the entire body's T cell population. So by circumventing this normal antigen processing pathway, there is an enormous T cell response. Now, how this actually occurs, this little black figure here, people have spent their entire research career studying this. It's way beyond kind of the scope of our lecture, but just know that the reason superantigens are so potent is that they can, activate up to 200,000 times more T cells than a normal antigen. So what does this mean? So you have superantigen, it's going to activate our T cells. And as you guys know, T cells release a bunch of cytokines. And again, you're releasing, in this case, you're releasing up to 200,000 times more cytokines than you would have with a normal antigen. That cytokine release does a lot of different things, but what ultimately ends up being the most concerning is you have the systemic capillary vasodilation, which ultimately leads to hypotension and shock. Okay. All right, so let's talk about M proteins. So M proteins play a critical role in group A strep-induced toxic shock syndrome. So here, this is our specimen of group A strep. So remember, group A strep is gram-positive cocci in chains. Okay, so gram-positive, meaning it'll look purple on the stain, cocci, circular shape, and chains as opposed to clusters. So there's our GPCs and clusters that would hopefully show up on our blood cultures. But on the surface of these bacteria, you have these M proteins, which can be released and then form an aggregate with fibrinogen. That aggregate can then go and activate leukocytes, specifically PMNs. When the PMNs are activated, they can bind to the vascular endothelium and cause a lot of local destruction. Okay, so here you have the M protein, it activates your leukocytes, they bind to the vascular endothelium, they release a bunch of enzymes, you get a lot of vascular leakage, and it also induces hypercoagulability. That in turn leads to hypotension and DIC. So as you can see with the superantigen and the M protein, these are really driving the processes that kill these patients, which is multi-organ failure and often DIC. All right, so I want to talk about the 6 R's to toxic shock syndrome. So we've got recognition, resuscitation, removal of the infectious source, a rational antibiotic choice, the role of adjunctive therapy, and how to reduce risk and close contacts. So let's talk about recognition first. It's super critical that we know how to recognize this syndrome, because one of the many reasons why there's such a high mortality rate is because we often have a delay in actually recognizing it. The other thing that causes a delay is that early on, symptoms are often indistinguishable from like an influenza type illness. So as I've kind of alluded to in the past, you are going to have symptoms from the toxin mediated process, which is going to be the hypotension, the capillary leak leading to pulmonary edema and DIC, fever, chills. But then you can have you can have the local infection or symptoms from the local infection itself. So really kind of a wide variety of things from sore throat to nausea and vomiting to pleural effusions, somnolence. And then a key one to point out is the dermatologic manifestations, which we'll talk about. Now, the CDC has established this kind of drawn out diagnostic criteria to help us recognize this syndrome, though there are a lot of drawbacks to using these criteria. One, these criteria were initially established for research purposes. So while they're quite sensitive, they're not very specific. The other thing that creates a shortfall in this criteria is that some of the items can only be filled in retrospect. So while it's good to be familiar with them, these don't always drive a diagnosis. So in short, though, what you have is you're going to have signs of systemic illness, which you can see with the fever, the hypotension. You're going to have some type of dermatologic manifestation, and then you're going to have multi-organ system involvement, and that's essentially what this criteria spells out. The criteria for strep is slightly different, and the main reason there is that in streptococcal-induced toxic shock syndrome, you're much more likely to have positive culture data. Whereas in staph, only about 5% of the cases will get culture data. So having positive cultures from a site that shouldn't have it for strep will meet one of the major criteria. But instead of memorizing or having to look up those criteria each time, I like this table because it really puts it down into a nugget that you can pack in the back of your brain to help you remember how to recognize this syndrome. So basically, if you have a young patient with a viral-like illness that's in septic shock, but there's no other alternative etiology, think toxic shock syndrome. If you have a patient who has a focal soft tissue type infection or pain, but the pain seems to be way out of proportion to what you would expect on exam, and there's evidence of systemic toxicity, think toxic shock syndrome. Okay. Alternatively, if the patient's vital signs seem to be way out of proportion to what you would expect, think toxic shock syndrome. So essentially, if you don't have an alternative etiology and a patient's critically ill, this needs to be on your differential. Or if you kind of have a differential, but the patient seems to be sicker than what you would expect, you need to be thinking toxic shock. Okay. So I wanted to cover the dermatologic manifestations briefly. The classic thing that we hear about is this desquamation, but this often doesn't occur until 1 to 2 weeks after the patient initially gets sick. So at this time, the patients are often dead or discharged from the hospital. And so we may not see the desquamation very often, especially in a disease that's relatively uncommon. But most patients will have some type of diffuse erythroderma at the time of presentation. Now, this can be really subtle. It can be easily missed. But the rash you see on the left generally is present in some form early on in the disease process. But I know we all take all of our patients' shirts off and do a thorough skin exam, so none of us should miss that. Yeah, so I didn't see what you said, or didn't hear what you said, Dr. Kennedy, but I could tell it was a smart comment. Okay, so the second R, resuscitation. There's nothing cryptic or special about this. Just know these patients are critically ill. You've got to be really aggressive with their resuscitation. They need a lot of fluids. A lot of times they're going to need vasopressor support. A lot of times they're going to need to be mechanically ventilated. Obviously, they wouldn't be on our floor if that's the case. But in short, be aggressive with these patients and have a really low threshold to call the ICU. Okay. All right. Let's talk about removal of infectious source. So these are some of the most common things that we see. As I've already mentioned, feminine hygiene products are commonly implicated in toxic shock syndrome. And the reason for that is the vagina is typically an anaerobic environment, but as a foreign material is inserted, it can cause some air trapping, leading to an aerobic environment, allowing our aerobic gram-positives to thrive. So this can be tampons, it can be IUDs. Other things, nasal packing. So the one time that I saw this disease in residency was a guy that came in with severe epistaxis and had a lot of nasal packing placed. And he quickly got sick. We thought he was bleeding again, but turned out it was toxic shock syndrome. Any type of wound packing has got to come out, and pus has to come out. So it's kind of a broad term, but if it's a surgical site, it probably needs to be debrided and opened. If it's an abscess, it's going to need to be IND'd. And this is kind of the case for a lot of infections, obviously, but I really want to hone in on the importance of getting the infected source out. Take home point here, any recent surgery needs to be reevaluated by the surgical team, even if the wound looks fine. If somebody's recently had any type of surgery and they developed toxic shock syndrome, you need to call the surgeons to come and glance at it, okay? All right, so let's talk about antibiotic choice. So these patients, like any other patients who come in septic, generally start them on vancomycin, okay? Looks like we have a question from the audience. Meryl's asking about Clinda. She said that she always hears about Clinda and toxic shock syndrome. So we're gonna, we'll come back to this in terms of how we use Clinda, but just to point out, we're not directly using Clinda for its, for lack of a better phrase, antibiotic properties. The reason for that is one, a lot of strains of MRSA are resistant to Clinda, but two, Clinda is bacterial static as opposed to bacterial cidal, but it does play an important role. So that is a perfect segue into our next R, which is the role of adjunctive treatment. So let's talk about Clinda for a minute. It has a lot of properties that make it an excellent therapeutic agent in toxic shock syndrome. So first of which, it inhibits our superantigen toxin production. So there's our happy superantigen, and then his kryptonite comes in and stops the production. So I couldn't find a cartoon with Superman frowning, so I had to use my mad Photoshop skills. This was before, that was after. But superantigens do not like Clinda, okay? Clinda stops them from being produced. The other thing that Clinda does is it overcomes the eagle effect. Got it? Good. Looks like we have another question from the audience. Looks like Mr. Obama was not paying attention in medical school, and he says he doesn't remember what the Clinda effect is. So thanks for asking, Barack. I guess we'll cover it real fast. So we need to review how penicillins and beta-lactams work, and that will help us understand the eagle effect. So beta-lactams kill bacteria by binding to the penicillin binding protein. So it's an aptly named protein that lives on the surface of bacteria that allows the drug to bind to and eventually lyse the cell membrane, okay? The eagle effect refers to the portion of the bacteria's growth phase in which there is decreased expression of the penicillin binding protein, okay? And if there's not a lot of binding protein, the antibiotic can't bind. And so during that particular part of the growth phase, if there's not a lot of penicillin binding protein, the beta-lactams cannot bind to the bacteria, and therefore it's not going to be near as effective, okay? Clinda, on the other hand, does not bind using that binding protein, and therefore it can overcome this effect. So in short, this is a streptococcus during the stationary growth phase, and this is what Clinda does to it. So it's able to overcome and ruin that streptococcus's day. All right, so we talk about the two most important factors with Clinda. It inhibits superantigen production, and it can overcome the eagle effect. But it has a couple of other properties which helps too. So it stimulates phagocytosis, and it also has this excellent tissue penetration, okay? So again, we're not directly using Clinda because it can kill the bacteria directly, but it's a perfect adjunctive agent to help. All right, so what about IVIG? So let's briefly talk about what IVIG is. So it's literally intravenous immunoglobulin. So you're injecting antibodies into patients. Okay, so IVIG is created by basically collecting antibodies from a massive portion of donors. So everybody that donates blood, the plasma can be spun down, antibodies can be isolated, and basically it's thrown into a cake mixing bowl, spun up real good, and then injected into patients who need IVIG. So what odds are, since this is really coming from thousands and thousands of donors, odds are is that you'll have some antibodies that will have an affinity for the superantigens or the M proteins. So theoretically, it should be tremendously beneficial. Now, the evidence that exists is limited to case reports and retrospective reviews. So it seems as if this would be a great therapy, and there's some limited evidence, but there hasn't been any RTCs that show that IVIG is beneficial in toxic shock syndrome. Take-home point here is I would probably use IVIG in severe toxic shock syndrome, though frankly, if somebody has severe toxic shock syndrome, they're not going to be on the floor. This is probably not a decision that we would routinely make, but the risks are relatively minimal, and there's certainly potential for moderate benefit. So just something to kind of keep in mind. All right, and then lastly, the last R, reducing risk in close contact. So there is evidence that household contacts of those patients who develop toxic shock syndrome due to a strep infection are over 100 times more likely to go on to develop an invasive strep infection themselves when compared to the general population. Now, where the evidence here is weak is should we be prophylactically treating all of the household contacts of these patients? Probably not yet. There's not enough evidence to say that we should do that routinely, but just be aware that this is a phenomenon and is an important thing to educate families. So if you've got a patient with TSS, you need to be telling their families, hey, if you guys start feeling bad, you need to be checked out soon. Okay, so let's kind of summarize everything that we've talked about. Most cases of toxic shock syndrome are caused by staph or strep. Okay. Superantigens and M proteins are responsible for the seemingly out of proportion physiologic response and decompensation. In terms of therapy, we need to immediately start aggressive resuscitation and broad spectrum antibiotics along with adjunctive therapies I mentioned. And then a full skin exam is critical. Any foreign bodies have to come out. Okay, this is as important as starting antibiotics. If you miss a foreign body, odds are the patients aren't going to survive. Any infected wounds or recent surgical wounds need to be debrided and packing replaced, and then have a really low threshold to call surgery or the ICU. Okay, these patients can crash really quickly. All right, so we go back to our case. I was asking about best adjunctive therapy. So the correct answer is Clinda, though IVIG, is something to consider as well. So that's all I got today. Like I said, it was going to be a shorter version, but I thought this was a good summary of something that we don't see a whole lot, but if you miss it, your patients are going to have a very high fatality rate. Okay, so it always kind of needs to be in the back of your mind for any patient that comes in septic. You guys have any questions, concerns, comments?
Tim, this is Roman. Thank you for this excellent presentation, actually. Just one addition to the antibiotics that you could use in terms of toxic shock syndrome, particularly in staphylococcal. When you have resistance to clindamycin, it's theoretically, even though it's toxin production that it inhibits, but when it's staphylococcal, might not be the greatest. In that case, we favor the use of linezolid because it has anti-staphylococcal properties. And there's some literature that says that theoretically, the use of linezolid and clinda in combination probably it's even better because you have the bulk properties at top, actually. So that's the only thing.
Yeah, thank you. Thank you very much for adding that. I did a ton of reading, but I should have ran this by my IB colleagues. I appreciate that comment. Any other questions? Okay, good. All right, well, I appreciate everybody tuning in. I'm going to send out a short evaluation on SurveyMonkey. If you guys want to keep continuing to get CME credit for these sessions, we have to have evaluations. So if you get a link, please fill it out. And I'll also send out a link to the YouTube channel once I get that created. But anyway, thanks for tuning in. See y'all later.